Well, good afternoon and welcome to CEDA's live stream, Pandemic to Endemic Beyond the Jab. For those of you who don't know me, I'm Melinda Cilento, the CEO of CEDA, the Committee for Economic Development of Australia. Can I start by acknowledging the traditional owners of the land in which I'm joining you from today, the Wurundjeri people of the Kulin Nation, and pay my respects to their elders, past, present and emerging, and to thank them for sharing their traditions, culture and history with us in the spirit of reconciliation. Well, right from the start of the pandemic, CEDA has been really focused on bringing to its members and wider audiences timely and relevant information on COVID-19 and what it means for our economy and our society, how we respond to it and how we look to the future and think about coming out of the pandemic. For me personally, I've been of late very interested in exploring the many ways that we might broaden the tools that we're using to respond to this pandemic, to chart a path out of the lockdowns and the hotel quarantine and things like that we've been so accustomed to, particularly those of us in Melbourne. Today's conversation is another chapter in those conversations, if you like, to help us to understand how we can move from what has been an approach to elimination and zero cases to something different, how we stick the landing from zero to living with COVID in a way that many around the world are now doing, but we're finding our feet on, if I can put it that way. Delta, of course, has delivered another set of challenges and I think has actually now focused us on the fact that we're not going to get back to zero cases and we are going to have to think differently about how we manage the COVID-19 crisis, both in terms of the impact on our economy as well as our community and society more broadly. So I think it's going to be a pretty interesting conversation that we've got. Our speakers are going to be introduced later, but I did actually want to just take one moment to thank Peter Doherty for joining us. Peter is a member of CEDA's Leadership Council, and he has been a regular contributor to our content on this really important subject. So I did want to just acknowledge him and thank him as such an important supporter of CEDA's work and our events. Now, we've got a tremendous audience who's joined us today for this live stream. Not surprising, I think, given the speakers that we have and the importance of this topic. But of course, we also want to make sure that you can not just listen to the insights that our speakers are going to deliver, but also ask your own questions and participate directly. If you haven't already done so, please log in through the Pigeonhole app. The details are on the screen there. You can either click through the live stream page or log in via the URL ceda.pigeonhole.at. And the password is Beyond the Jab. Of course, we also love for you to be involved on social media. Please tag us at CEDA_news, tag me at Melinda Cilento, and the hashtag is Beyond the Jab. Finally, of course, would love to thank our sponsors, GSK. Sponsors play a really important role in helping us bring this really important content to you, our audience. And to invite to make some opening comments, Christi Kelsey, who is the Managing Director of GSK Australia. And I think she's going to set the scene for us and introduce our speakers. Over to you, Christi.
Thank you so much, Melinda, for the introduction and the opportunity to be with you today. As you mentioned, if you think about today's topic, it's about how do we pivot to a new future beyond the jab. And I know I speak for many when I say that the daily COVID press conferences have become a bit of a weekly ritual in my household. But if you really stop and think and recognize that the cases continue to rise due to the variants of concern. Lockdowns, I'm also, Melinda, in Melbourne, lockdowns really, no matter where you are these days, do continue to be extended. It gives us a reason to have a dialogue that we're going to have today because there are new questions that we need to think about. Specifically, how do we learn to simultaneously manage but also live with the COVID-19 virus. I think it's become very clear to us that this virus is not going away anytime soon. And we need to think beyond the elimination and suppression strategies in this pandemic that we've become very familiar with, and talk about what's needed to get to the endemic phase. Now, just a couple of reflections. Naturally, the prevention and the non-pharmacologic treatments and interventions have been certainly the cornerstone of the Australian response so far. But the reality is, and we need to accept, that there will always be a percentage of the patient population that is not vaccinated for whatever reason, for a variety of reasons, as well as a population where vaccination wasn't sufficient. So then that brings us to the question today: what else is needed? How do we transition beyond the jab and move from pandemic to endemic? And what strategy is the best one? And I think when you think about a strategy, I think what we've learned is no one strategy alone is enough. And I can share with GSK our approach in response to COVID-19, I'm very proud to say, has been one of the broadest in the industry, looking at both treatments as well as vaccination. On the vaccination side, we are partnering with CureVac, and our focus is the next generation of messenger RNA vaccines. And we continue to supply our adjuvant technology, which is a cornerstone of our vaccination portfolio. On the treatment side, in partnership with Vir Biotechnology, we continue to focus on antiviral antibodies, looking both at COVID-19 treatment as well as prevention. But no matter the strategy, I think what's very clear is we need a very robust multidisciplinary approach. This has to be a community effort across all of our experts. And today we are very lucky to have two global experts to really start a new dialogue as we pivot away from a zero COVID world, recognizing that the variants of concern are making zero COVID quite challenging. So today I'm pleased to announce, and certainly these experts need no introduction, but I will do my best. Laureate Professor Peter Doherty, patron the University of Melbourne at the Doherty Institute, and Professor Raina MacIntyre, who's the head of the Biosecurity program and Professor of Global Biosecurity at the Kirby Institute at the University of New South Wales. So you are in great hands today with global experts that I know personally have guided me as I've educated myself on all facets of what it's taken to just learn the new terminology of a pandemic. But Peter, I think first I'll go to you for some opening remarks about the future and what other factors are important as we consider moving beyond the jab. So Peter, over to you.
Well, thanks very much. My expertise is in infection and immunity, particularly in immunity, and I've worked in that area for over 50 years. And as you're asking this question, where do we go from here? As we all understand, the path forward is vaccination. That's the best option we have available to us. And how that will play out is basically what we're trying to understand and what we've tried to understand and government has tried to deal with by seeking input from modelers, trying to learn from them as they lay out scenarios, because that's what models are. To my mind, they're basically thought experiments, very sophisticated thought experiments based on the best available data, and they've come up with scenarios based in that. Now, there's a lot of discussion and debate around that, maybe some overinterpretations and misinterpretations here and there. But what we can be sure of is that we will continue to be in the position we've been all along with this. We are basically part of a big experiment because we've never dealt with anything like this before in the way we're dealing with it now. We've been dealing with pandemics for a very long time, but we've never had this tremendous science, this tremendous acuity of diagnosis, rapid development of vaccines, and of some therapeutics. Unfortunately, the therapeutics have lagged a bit behind. One notable exception is GSK's monoclonal antibody, sotrovimab, which will hit any of these coronaviruses, any of the variants. That may prove enormously important and save many lives as we go through these next months. The government has ordered, I think, 7,700 doses. It could be 10 times or 100 times that as far as I'm concerned, because I can think of many applications. And we don't, at the moment, have those small molecule drugs that we'd love to have. So at the moment, we're relying on public health policy. We're relying on the willingness of as many in the community as possible to go out and take the vaccines. The vaccines are from the American experience. They're not made against this current strain, Delta, which is circulating in Australia. And Delta is about 3 times less likely to be stopped by the antibody response. But if we keep the antibodies high from vaccination, then the vaccines are dealing pretty well with it. From what we know in the American experience is the numbers of people who are vaccinated who are getting any infection, that's up in the nose principally, about 4 times lower. Number of people who are being hospitalized about 10 times lower, and the number of people who are dying about 11 times lower. And many of those who are succumbing are people who have defective immune systems because they're very elderly or for some other reason. So the path forward is going to be dictated by these various factors. We'd love to have more drugs that could be used right at the beginning when we're first diagnosed. We have the vaccines, they're coming through. Pity they didn't come through earlier, but they're coming through now. And so it's up to as many as possible to get vaccinated, both for their own sake, for the sake of their children, for the sake of their family, and for the sake of elderly people they may know and associate with. Because the vaccines, though they are protecting most elderly people and working remarkably well, are not protecting all of them. So partly it's up to us, partly it's up to the policy people, and we'll see how it plays out.
And Raina, why don't we go to you for some opening comments? Thank you, Professor Doherty.
Thanks, Christi. Look, I have a lot of hope for the future because vaccines are actually one of the most successful public health interventions in history when we look at things like polio and smallpox and, the childhood infections that used to kill most children in the 19th century. We've controlled them all through vaccines. They still occur occasionally, but we don't have the kind of, premature mortality of children and adults from those diseases. The other thing to remember is that the vaccine pipeline is dynamic. It is not static. What we have today is not what we're going to have tomorrow. Very soon in the future, we'll have booster doses, and we'll have booster doses exactly matched to the Delta variant, which will then drive the efficacy right up and reduce the herd immunity threshold. I believe we should aspire, to the highest possible goal. And I still think herd immunity is possible. We may need to give boosters. We may need perfectly matched vaccines to the variants of concern, but that's possible, particularly with the mRNA vaccines, which can be tweaked very rapidly to match variants of concern. And I think, I would like us to aspire to a situation like measles. We can't really aspire to eradication like we eradicated smallpox for various reasons that I won't go into. But I think like smallpox, which took over 100 years to eradicate after the vaccine became available and 20 years after the WHO set a goal to eradicate it, it's a long haul process. And I think I'm still quite optimistic. But one story I'll tell you, which is relevant to GSK, is there's a lot of negativity and pessimism. Last year we heard people saying we'll never have a vaccine, and I knew that was rubbish. I knew we'd have a vaccine. Of course we would. There'd never ever been the kind of global effort that we saw in vaccine development in history. We saw GSK and Sanofi, which are rivals. They never collaborated on a vaccine together. So we saw some really extraordinary things, and I knew that, somebody would come up with a vaccine. And of course, we've got many vaccines and many more in the pipeline. There's a vaccine for herpes zoster or shingles, which is quite a debilitating illness for older people. And the first vaccine that became available had an efficacy of around 60%, which is pretty good. And everyone says about older adults, because there's a thing that happens to our immune system. No matter how fit and healthy we are, when we reach the age of 50, our immune system starts to progressively decline. It's called immunosenescence, which makes vaccines less effective as you get older and older. And it also makes disease incidence more severe as you get older and older. So no one thought it would be possible to develop a really high efficacy vaccine against shingles in older people, and GSK did. They developed a vaccine that had an efficacy of over 95%. I can't remember the exact number, but it was very high, the sort of efficacy we're used to in pediatric vaccines. So anything is possible. You just have to put your mind to it. The technology has exploded in terms of, vaccine technologies, and some, the mRNA technology is a breakthrough as well. So I think it just needs the kind of concerted effort we've seen. So I think we will have much better, and we may even have a universal coronavirus vaccine in time. But for now, with the Delta variant around, this is much more contagious. It's, at least 3 times as contagious as the virus that caused the Melbourne second wave last year. We do need to rely on non-pharmaceutical measures. We know that vaccine alone with what we've currently got is not enough. We don't need to repeat mistakes that have been made not mistakes, but experiences of Israel, the US, and the UK, where they just relaxed all restrictions and thought it was all over, but the Delta just got them, right? It just came right back. Pediatric ICUs are full in the southern states in the US. So we need more than just vaccines in this interim period. So we need to use masks. We need to use social distancing. We need to kind of use little measures to reduce contact between people, but we also need to think about clean indoor air, safe air. We don't accept if dirty water comes out of our tap, but we accept dirty air all the time, whether it's bushfire smoke or viruses. So this virus is airborne, massively airborne. That's the dominant mode of transmission. So if you're sitting in a car or in an office with other people and the ventilation's not good, you're going to get infected, most likely, particularly with this Delta virus. So we need to pay a lot more attention to safe indoor air, whether it's schools, offices, workplaces, businesses, etc. And I think into the future, we're going to have challenges around urban environments and building design, so that in Australia particularly, we can deal with the increasing risk of bushfires and bushfire smoke, in which you want to keep the outdoor air out of the indoor environment. And the opposite is true for viruses. You want to bring the outdoor air in and push the indoor air out. So how do we design smart cities to deal with that in the long future? Over.
Well, thank you for those opening comments. Raina, could I just ask you, I am going to ask you, is it possible to get a shortish answer on why we can't eradicate COVID where we have eradicated things like smallpox, albeit with a longer time frame? Sure. I think it's just trying to get our sense around zero to where.
Yeah, there's 3 criteria for, 2 main criteria. 3 criteria really for the eradicability of an organism. One is it should only have a human host. If it's got an animal host, it's not going to be possible, because it's always going to be hidden away in animals, and that possibility of it coming back will be there. So that is strike 1 against SARS-CoV-2. The second is it should not have any asymptomatic transmission. When you've got major transmission happening before or without symptoms, it's really, really hard to control. Smallpox didn't have that. It was only contagious when you had symptoms. So you could spot someone who had the infection, they had a rash, and you could isolate them and stop other people getting infected. So smallpox was kind of the ideal disease. And of course, the third criterion is you need an effective vaccine, which we have for SARS-CoV-2, but the other 2 criteria make it extremely unlikely we'll eradicate it.
So thanks for my little science lesson there. To both Raina and Peter, perhaps a question about modelling and just how important it's become, but whether or not you think we're sort of using it in the right way now, if I could put it that way. I mean, everyone understands, Peter, that it's your model, apparently.
It's not my model.
You talked about scenarios, but I'm interested in whether we think that's how it's understood, and whether we need a different conversation with the community at the moment, or whether you think we're handling that well. Peter, perhaps to you first, and then Raina, if I could.
Well, I keep being accused of it being my model, but it's actually Jodie McVernon's modelling team, and I think 5 other universities are involved. They've written a very detailed initial document, which is up on our website, and then there are subsequent documents going forward, and I'm not across all the details of them. I have enormous respect for modelers. I think they're of great value, but part of the problem for these models is some of our assumptions. Models are based on various assumptions and scenarios. Some of our assumptions are pretty soft. We just don't have enough data yet on various aspects, like the extent of transmission from vaccinated people and so forth. We know vaccinated people can get infected and so forth, and so on. So you have to keep that in mind. They're not wholly writ. But I don't want to be disrespectful to modelers, because Raina's a modeler for one thing, and I think she's the person who's best qualified to speak about them, their limitations and their strengths. Because when you actually work in something, you know the pluses and minuses more intimately than those from outside. I love modelers. I listen to them. We involved them in some of our experimental work in the past. Didn't necessarily take that much notice of them, but that's where my experience was.
So I think you have to understand that different types of research are suitable for different research questions. If you've got a question about the efficacy of a drug or a vaccine, you need a randomized controlled clinical trial. That's the best kind of evidence. If you want to know if smoking causes lung cancer, you can't really do a randomized controlled clinical trial, because that's going to be unethical, and so you use observational epidemiology. If you've got questions of economics, you need an economic model. And if you want to know what's going to happen in the future, something that hasn't yet happened, the only way you can do that in a rational and scientific way is by using a model. And there's lots of different kinds of models. The kind that Jodie and team have done, the Doherty model, and the kind that we do is called an SEIR model, susceptible, exposed, infected, recovered. That's because infectious diseases are actually really uniquely suited to modelling, because people exist in mutually exclusive states of either being infected, exposed, susceptible, or recovered. And you can model the rate at which they transition between those states, and you can predict when sort of epidemics will happen based on what interventions you put in place, whether it's vaccination or social distancing or face masks and so on. Any model depends on the assumptions you make. And of course, there are bad models. It's, garbage in, garbage out. Generally, modelling should be transparent so that you can look at a model and understand exactly how it's been done and what the limitations are, etc. And any model will usually give you a range of scenarios, not just one scenario, and that's to account for uncertainty, both the uncertainty in the assumptions, but also the uncertainty in what public health action will occur. And I've widely been attacked through this pandemic for predicting certain numbers of cases or deaths. Now, every modeler, the purpose of modelling is to tell you what the worst case scenario could be. It's not to tell you what the best case scenario could be, because nobody needs to know that, right? That's just what we hope will happen. We need to know that we're prepared for the worst case scenario. So a model should give you a best, a worst, and then in between scenarios, depending on different policy decisions. And the reason we do worst case scenario modelling is to prevent those worst case scenarios from occurring. And usually, policymakers will take note and they'll think, we don't really want to have, the hospital system fall over on this particular date. We better do X, Y, and Z to make sure that doesn't happen, which is modelling at its best and informing good public health policy. So that's kind of it in a nutshell for me.
That was a very good nutshell. But let me ask a question. There's a question that's come through our Pigeonhole app around the disparate impact that COVID's had in different populations and different groups. And the question is really phrased around the fact that we've seen this crisis sort of splintering along similar sort of socioeconomic lines, if you like. We're seeing similar results out in the US as well around the impact on lower income households, the most disadvantaged. And so I'm interested in your thoughts on that. But But also, if I can kind of extrapolate, one of the things that's been talked a lot about now is that, what can we do when we get to 70% or 80% fully vaccinated? And that's an aggregate population view. But what happens if we get to those sorts of numbers, but other parts of the population are not at those levels? So we've got pockets of population that are well below those levels. What does that mean for what the next steps look like for Australia? And I'm happy for either of you to jump in on that.
Well, I can say something briefly. I mean, basically, the socio-economic thing's pretty obvious. I mean, these are the people who are at the bottom end of the social spectspectrum. They have to keep working. They have to keep out there. They're often living in much more confined conditions. And Raina talked about the air spread. Now, early on, when COVID came into a household, often many members of the household were not infected. And particularly, you didn't see very much in children. That's changed. When someone brings COVID into the household now, everyone gets infected. And it can be a kid that brings it in. Kids weren't bringing the virus into the household. Now they are. And that's because, as Raina said, this virus is growing so much better. It grows to a higher level, and that makes it more transmissible. That's all it's about. I mean, all viruses want to do, if they don't want anything, they're just a bit of genetic material wrapped in a bit of protein and fat and a bit of sugar. So all they do is, in an evolutionary sense, is transmit. So the faster a virus grows and the more it's pushed out into the atmosphere by us, the more it will transmit. And that's the difference between Delta and the original Wuhan strain. It's a virus that first emerged in India back in December 2020. Before anybody really started vaccination. It's just a virus that grows better and transmits better. We're worried now about, of course, variants that might jump the immune response. But as Raina said, we geared up to make variant vaccines. The Delta vaccines are already in trial with both Pfizer and Moderna. And our government has, I believe, ordered 85 million mRNA doses for 2022-23. So I expect my understanding is they'll likely be the booster shots given to all of us next year. And whether you decide to boost, say, the elderly with something else earlier is another matter, and which will obviously depend on vaccine availability. It would be good to get those antibodies levels up. I mean, the problem with age is we decline and our immune systems decline, as Raina said. So what happens next? I think Raina's probably got a clearer thinking about that than I have.
So I might just go back to the title of, about the word endemic. A lot of people say COVID's going to become endemic. It's never going to be endemic. It's always going to be an epidemic infection. There's a technical difference between endemic. There's three types of infections: endemic, epidemic, and sporadic. Something like hepatitis B is an endemic infection. Malaria is an endemic infection. You can have very, very high levels of disease, but it stays relatively constant. If it changes over years, not over days. An epidemic infection has a high reproductive number, and it'll change rapidly over a short period of time, days to weeks, which is what makes health systems unstable and kind of really challenges critical infrastructure, etc. So wherever you've got pockets of unvaccinated or undervaccinated people, or people whose vaccine immunity is waning, the virus will find those people and cause outbreaks. We've seen it with measles. We had a huge outbreak in 2012. Even though we've technically eliminated measles in Australia, we still see outbreaks in those undervaccinated pockets, whether it's Byron Bay and the Northern Rivers area, which is has higher rates of vaccine refusal, or whether it's Southwest Sydney, which, in this case, the big measles epidemic, there were pockets of people from certain, Pacific Islanders, Samoan people who were travelling between New Zealand and Australia and unvaccinated, big family groups, crowded living circumstances, and you see these huge outbreaks. Just look at Wilcannia, 7% vaccination when the outbreak started there compared to probably 40% in Bondi or Wahroonga. So when you've got inequity in distribution of vaccines, those groups will be extremely vulnerable, whether it's an aged care facility, a disability facility, or a community group that's disadvantaged.
So, Raina, if I can just follow up on that, then does it, if we get to 80%, but there are still these pockets who haven't got those vaccination rates, does that, in your view, change what we should be doing, or is it just where we're at?
Yeah, my personal view is 80% of 16 plus, right? Not 80% of the whole population. That translates to about 64% of the whole population, which is about the rate that Israel was at when they released all restrictions. And we just have to look at what happened in Israel. We'll have a massive resurgence. There's no way that 80% of adults vaccinated will control Delta. We need the other measures. We can't relax the mask mandates. We need to keep them. We can't drop our contact tracing. And the two most influential other things that we can do is, one, find every case and isolate them. Two, trace the contacts within 24 hours and quarantine them. That is not happening. The rapid contact tracing is probably not happening in most cases now in New South Wales because the capacity is just too great, the required capacity. There's digital methods to do that. We need to be really looking into, scaling up those digital methods. If we've got to overcome privacy barriers, well, do it. We've got public health legislation that enables us to overcome individual rights in the interests of the public. We need to use everything at our disposal. And I'm all for, using public health legislation to get automated digital tracing methods.
So, sorry, Peter, go.
Yeah, the analogy I've been using I've been trying to talk to people who are sort of resistant to the idea of evidence, which is what people like Raina and me work from, kind of our best estimate of evidence-based reality. And I've been trying to use analogies, and I describe viruses as the ultimate leak test. It's a plumbing exercise. If you've got a hole somewhere, the virus will find it. And we've been seeing that over and over. So Israel opened up at the sort of level we're talking about opening up, and we all saw what happened. I don't see why we should expect anything very different. And we're going to have to use public health measures just as we've been using. And I think that's inherent in all the modelling documents. So it's simply a reality of life. Often in Australia, we decide we have to reinvent the wheel for some reason, and we don't. We can see what's happened elsewhere. And because we're behind, because of I think we've been protected by our island status more than anything else. And of course, Delta has shown us that's no longer a protection. Once it's established, as it is in New South Wales, and I believe in Victoria, we're not going to get rid of it. I mean, Victoria has locked down even harder than New South Wales. It worked for us in the past, it hasn't worked now. So the virus is here. It's opening us up. We need to get used to it. We may have to get used to the idea we're kind of two countries for a while, because quite frankly, I don't see people, premiers in states that don't have any virus active, opening up because we reach a magic 80% vaccination level. Personally, it doesn't make any sense to me, politically or in any other way.
So I'm going to start trolling through the many questions that are peeling into the pigeonhole now, one of which I think relates to this, which is, can we just rely on basically natural or herd immunity as distinct from a sort of an implicit or explicit mandatory vaccination policy?
I might answer that. The word herd immunity, just like the word elimination, eradication, all these technical terms have been widely abused and misused during the pandemic. Herd immunity is a concept that arose from vaccination. It's when enough people are vaccinated to protect the unvaccinated. And there is a herd immunity threshold that you can work out by the R0 of the reproductive number. So for the Delta strain, you're going to need probably 90% of the population immune, not vaccinated, but immune. So that's a hard ask for the current vaccines we've got. But I think it's actually going to be feasible with future vaccines that we'll have, and we should aim for it. We've achieved elimination of polio and measles in Australia, which is that we do not have, that outbreaks may occur as they do with measles, but they'll never take off like the Victorian second wave or like this wave we're having in New South Wales. They'll be controlled pretty quickly because it hasn't got anywhere to spread beyond the initial little pocket that it takes off in. And I think we should aspire to that. I don't believe we should aspire to living with mass death and mass illness, which is going to, disproportionately affect disadvantaged people, of course. and it's also going to decimate our health workforce. In countries like the US, we're seeing health workers just leaving, quitting. They don't want to work anymore. It's too traumatic to be treated so badly, and then to just keep saying, especially in the US, they had this period where they thought everything was going to be okay, and then it all came back, these huge waves of Delta and pediatric kids, filling up the hospitals. And the other thing is our children. They're going to be the biggest unvaccinated group. I think there's a lot more we can do to protect them. We don't, I certainly think the UK model of let's just infect them and get herd immunity through infecting our children, I don't agree with that. I think we can, for a start, open the windows in the classrooms, get air purifiers in, work out logistics of how you run lessons safely. There's so much more we can do to make classrooms and schools safer than just, chucking the kids back in there and hoping for the best.
And the other thing we have to do is to get everyone who's around the kids vaccinated. We can vaccinate the teachers, vaccinate the cleaners, vaccinate everybody, and make sure we're vaccinated, because kids do get infected with Delta. They do get sick. They don't get as sick usually as adults, and they don't usually get as sick for as long. But if the virus comes into your household and you're not vaccinated, and you get the infection and your kids get the infection, you need to be there to care for those kids, because they're much less likely to be hospitalized. So it's really important that all parents get vaccinated. We've seen absolutely toxic propaganda out there against vaccinating women, against vaccinating pregnant women, totally manufactured nonsense taken from the deliberate misinterpretation of research papers. The idea that the vaccine will make you sterile, a total rubbish. The idea that it will cause long-term infertility, complete nonsense. And natural immunity by infection, what a lot of these people don't want to talk about, is long COVID. And this terrible, debilitating disease, which is at really pretty high incidence in people who catch this infection. And you can also see it in kids. So the more we can avoid getting to natural immunity, which is a term I absolutely abhor, in fact, I think the better.
Yeah, I agree with that. Natural immunity, you can just look at Manaus, Brazil, where they had probably 70% of the whole population infected towards the end of 2020. And then they had a massive second wave where everybody got reinfected. So although there's one or two papers that a little bit controversially suggest that natural immunity might be long-lasting, in general, that's not the observation in the field. And even in the vaccine trials, when several of them present data comparing the vaccine-induced immunity to the natural immunity, and the vaccine immunity is much, much higher. So you want that vaccine immunity, and if you've been infected, you want one dose of vaccine at least.
Yes, what the infection will do is prime your immune system. And it will prime it well or not so well. And we saw that very early on. Some people were not getting well primed, and we weren't seeing antibodies in them. And we were seeing reinfection as early as August, September last year of people. And so if you are immune, though, or you've been infected and you are boosted with a vaccine, that will drive up the numbers of those cells that are against the spike protein, which is the ones we want. So there's absolutely no reason not to vaccinate people who have been infected. It will improve their immune response. Some of them will be perfectly well protected, some won't. But it's not what we should be thinking of relying on. And the perception in some quarters that this is what we should do is not really a very sensible and sane one.
It's not ethical either, because why would you commit to a strategy that's going to cause suffering and harm in people when you could avoid that? If not through vaccines, then through other measures like masks and ventilation, safe indoor air.
So I asked the question before about different populations that we're seeing are not getting the vaccination rates up to the levels that we need to. Do either of you have a view on, what we could do better? The communities that seem to be being left behind, what can we do to sort of actually improve those outcomes so that we don't get the sort of, the tearing of the social fabric that it looks like we're starting to see something of?
Well, basically, you have to communicate properly. You have to get influential people in those communities involved. And sometimes their communities have a different language base, a different cultural base. So if it's the religious leader, the local doctor who's widely trusted, the community leader who's widely trusted, and you have to start get messaging out there in those languages, not just. And then I think, which is enormously important, and I think New South Wales is doing it, we're doing it, is targeting this, getting the vaccines to the people. Because it's sometimes quite difficult for these people to actually find the time or the opportunity, and they're intimidated by some of the communication processes to actually get it. So get the vaccines out to the people. I couldn't believe it when I heard, and I didn't realise this, that vaccinating people in those aged care facilities, they were vaccinating inmates, but not in vaccinating staff. I've never heard anything so stupid in all my life, because these are the people who are likely to bring it in. They're coming in from outside. So we need to do this, to target the communities and get vaccine teams to them. Northern Territory started doing this very early with Indigenous communities. Victoria's done it, but it doesn't have that big an Indigenous population. But that's what we have to get. And we have to think very much about the situation in remote communities too, because they have very, very limited medical services. You just need to get a few cases there. You've taken out whatever they've got. There's no one there to deliver the babies. There's no one there to deal with the road accidents. Yeah, so we really have to target small rural communities and try evacuating someone with COVID in an air ambulance. I mean, it's enormously challenging.
To be honest, I think, Australia has a fairly vaccine accepting population. We've taken a fairly good situation and made it worse, unfortunately, through a series of things that have happened this year, which I won't go over. But I still think the biggest problem has been supply. Supply is what has restricted the availability in regional areas and the sort of rationing of vaccines in aged care, etc. I think when the supply is free flowing, we'll see people getting vaccinated. There are always anti-vaxxers, but there's a bigger group of people who are a little bit hesitant, who can easily be brought around. But as Peter said, we need culturally appropriate communications and engaging and working with community leaders to do that. And I think New South Wales does it pretty well, actually. I think so do most states. So I'm still hopeful that we won't have the US-style problem with anti-vaccination.
The anti-vaxxer thing here is not monolithic. It's a disparate group. There are really core, resolute anti-vaxxers who see this as a religious commitment on their part, but a lot of people who are anti-vax some people are terrified of getting a vaccine for some reason that I don't understand. It's not that. It's a very vocal and noisy group. But it's not that significant. I think it's more the vaccine hesitant, the people who really don't understand, who haven't really got the message, and that need to be brought along by community influence. Maybe mandates in various situations will work. Maybe they should be paid $300 when we get to the end of it. But who knows? I mean, there are various ways, and I think we can see the media message going out is getting more and better and better. And I suspect that really reflects that up till now we just haven't had the vaccine supply, and we're still short. And I hope basically by pre-ordering, we're not going to run short at the end of the year, because the US is going to start, if the safety and efficacy guidelines work out in the current trials, the US will start vaccinating children from 5 to 11 probably in January, and maybe infants a couple of months after that. And I think we should also be prepared to offer the vaccine to parents and younger children as soon as we possibly can, because apart from anything else, they can get very sick, they can die, not at the levels we're accustomed to, but the numbers of paediatric beds and paediatric ICU units in the country is not unlimited.
Yeah. And can I say, in the US, in 2017, which was the last really bad flu season they had, there were about 184 children who died of flu. This year, in a period of just 4 months, there's been 444 deaths in 45 states in the US from COVID, right? So So it's a bigger problem than flu. You know, we're out there encouraging kids to get vaccinated for flu. We should be doing the same for COVID. I agree with.
And the US has had a double hit from respiratory syncytial virus, which has made it even worse. So when you get a respiratory disease season, you will possibly get some kids in ICU for various reasons. And there's we just have to hope that if we let this thing run, or as it runs, we don't get into that situation. We had the heads of the major US children's hospital all signing a letter sort of saying, get vaccinated as soon as possible, do the right thing. But of course, as you know, there's some very strange behaviour patterns in the United States at the moment.
So let me jump to the number one question, which I've sort of had parked on the sidelines for a bit, which is about what all this means for international borders. I mean, we're a country that's relied so heavily on immigration, and we're a country of immigrants, really. So it's a very unnatural circumstance for us, really. Do you see borders opening, international borders opening soon? How should we be thinking about that based on your expertise, number one? And number two, I think, Peter, you spoke about, states that haven't got cases not being all that inclined to open up, irrespective of what's happening in New South Wales or Victoria. Is it reasonable that those states are going to be able to maintain zero cases? And when you've got disparate circumstances, how do we think about that, what different states are going to be doing?
Well, personally, and I'm not a policy person, but basically, if they don't have any cases, why would you open them up if they're living reasonable lives and people are having a reasonable time of it? Opening up international borders, as long as it's only Delta that's circulating in the world, well, that's fine. We've already got Delta. But there are some other viruses out there that are quite disturbing. There's one called Mu, which is a bit worrying. There's Lambda, and God knows what else comes along. So having certainty about this, I think, is really quite difficult. But Raina's probably got clearer thinking about this than I have.
Well, I think to do it safely, we need to pretty massively scale up the quarantine system, because in the end, vaccine passports are coming, whether we like them or not. And the vaccine you had, whether you had a booster, all of that's going to matter. In the end, my prediction is the vaccine you had and whether you've had a booster will determine what kind of quarantine, if any, you're going to need, whether you can go into home quarantine or whether you need to go into a dedicated facility. And I think, we should start scaling up that capacity, both the purpose-built facilities, but also the hotels, which can be made a lot safer than they already are if we just address ventilation, which has been done, I think, in Victoria and South Australia maybe, but not in New South Wales. And if we do that, I think we can open up in a phased way and in a safe way.
So one of the other questions that's come through, I think, Raina, you've already touched on as well, which is the sorts of protocols and policies that we're going to have in place. And the question is really around the fact that business has had to undertake really strict measures, including obviously closing for business. How do you see the sort of protocols and policies that workplaces are going to have to get people back into the offices and into the shops on a safe and sustainable basis?
I think I was talking to a certain Lord Mayor recently and suggesting they do a pilot project of a star rating system for businesses, whether it be restaurants or other kinds of businesses, where you award a star rating based on vaccination rate of staff and the ventilation. In countries like some European countries, they've mandated that restaurants and other public kind of premises have a carbon dioxide monitor at the front door. So a client or a patron can have a look and decide for themselves if they're willing to take that risk of going into an unsafe indoor environment. That's what we need to be doing. If business wants to open, let's all do that. Let's start putting in systems that can, I think it's going to need a layered approach. And I think have systems for testing it. I'm all in favour of mandatory workplace vaccination and think about design issues and other things that can mitigate risk. And if it's a layered Swiss cheese kind of approach, I think businesses can open safely.
But I think what I'm hearing you saying is that it's not going to be, it's going to be still masks, still some distancing, plus. Is that right? Plus
for the time being, for the medium term, until we get better vaccines, which we will. I'm certain we'll get better vaccines. So it's not, we've got to think we've come this far. We're nearly at the finish line. Let's just not throw in the towel and say, oh, it's all too hard. Let's just kill everyone, No, we've got to hold on. We've got to do what we can to make it safe so we can all enjoy life and be productive, get our businesses going. And I think we have to just stop, yearning for life to be what it was in 2019. We have to accept life has changed forever. Some of those changes might be good changes in that, we've learned how to work in smarter, more effective ways. We don't always have to travel 36 hours for a meeting to go somewhere else. We can do it virtually. That saves money, saves the carbon footprint. So I think we've got to, the sooner we just accept that the world has changed, this is a serious, major, unprecedented change. We can't just, yearn for the past and kind of stick our head in the sand and go into denial and hope it'll all be okay, because it won't. We have to actually tackle it head on and develop layered strategies for maximal protection so we can get on with the things we want to do.
Yeah, with respect to air handling, there's been quite a bit of re-engineering has gone on in our hospitals and so forth. There's also, early on, they bought some, I think, air purifiers from Kmart or somewhere. They weren't very sophisticated, but they actually worked pretty well. And so, there are simple solutions, not actually rebuilding a whole system that can be used, at least in the short term. I think the other thing we'll see probably rolling out is we haven't been using them because they're not as sensitive as the PCR test. But as the numbers get higher, there'll be a real application for rapid antigen testing. These things cost about $5 a time. You can hand them out. There are various ways you could use them, but I think they'll be very useful for sort of monitoring what's happening in a workplace, and we'll get wide acceptance. There's been a lot of work done in our institute in particular on actually evaluating and finding the best ones and the ones that should be recommended. So there are various ways forward. Also,
Peter,
what we have to hope...
Peter, you've got me on my soapbox because I've been saying the PCR test has been fantastic, but it seems like we're using an expensive, time-consuming diagnostic test for screening when rapid antigen testing would be a good thing. And we'll have to get you back to come and talk on that. Can I just ask one other question, which is sort of where we started a bit, which is the sort of therapeutics, and one of the questions that people are interested in is whether we'll see over-the-counter medications for the treatment of COVID anytime soon, and is that going to be part of the suite of tools that we need?
The therapeutics at the moment, we have the sotrovimab, which is this monoclonal antibody, which I think you could, if you had unlimited amounts of it, and it's an expensive treatment. I think it probably costs $5,000 or something like that. But if you had unlimited amounts of a therapeutic that would clear the virus, an antiviral, you could have someone test PCR positive. If it was a packet of pills, you could just hand them the packet of pills and say, take this. And you would stop the pandemic or the epidemic in its tracks, because you would stop virus transmission. And we've got this situation now we've never had for any other infection, where you test everybody who gets a sniffle. And you could do that, but we don't have it yet. There's a drug called molnupiravir that's going through the pipeline. It's a Merck drug. I think the Americans have pre-ordered some, but it's still being trialed, which may be useful. Looks reasonably good from the trials. Pfizer has a drug in trial. There are no doubt other ones that are in trial. We will see these come through, and they're going to be very important, because what they do is they target all the variants. They target parts of the virus multiplication cycle. So you're not worried about these variants that have selected to escape the vaccine. You've got something which will hit all category. We could be using those with flu, for instance. We have drugs that work right across all the influenza viruses. So if someone's diagnosed with flu, if we gave them immediately, because you have to give them fast, you could stop the infection. So I think monoclonal antibodies drugs are going to be an important thing for the future. But what's really important is that governments and everyone should learn from this. They should actually take home lessons. And there are all sorts of lessons at all levels. Medicine, the social framework, social equity that need to be learned. And unfortunately, I'm not sure some of our politicians are capable of learning those lessons. And I find that rather sad.
I mean, just to add to that, I think, it's in our interest to invest in more vaccine and drug manufacturing capacity, forming partnerships with companies, etc., because it's become apparent that, Australia could be a regional hub. To look at what happened with India. They are the largest. I think they have the largest vaccine manufacturing capacity in the world. But when they were hit with the Delta epidemic in March and April, they weren't able to even supply their own population. And we had parts of Africa and most of Asia relying on Indian-made AstraZeneca. They couldn't supply them, so supplies stopped everywhere. So South Korea has sort of developed manufacturing capacity to sort of be a regional hub, but I think Australia could as well.
I think great. We should be making the mRNA vaccines here, and I think there's a market for the long term. With flu, when we have a bad flu year, I think we make about 300 million doses of flu vaccine. Maybe it's better than that, but it's not that much better than that. And there are about 8 billion people on the planet. So, pretty much everyone goes short. We could be targeting a much broader spectrum of diseases with vaccination and reducing this toll considerably. And we could be doing, in a flu pandemic, we could be doing what we're doing with COVID, not the lockdowns and everything, but testing immediately and treating, because we have those drugs. And if you're thinking of COVID, a $5,000 treatment with a monoclonal antibody compared with maybe $25,000, $35,000 a day in an ICU is a pretty good deal.
Well, thank you, both of you. You sort of answered a question that I didn't get to, and I think you gave me a sense of what you'd like the answer to be, perhaps more than giving an honest answer about where you think we're at. And that question was, do we think that this COVID experience is going to actually change the way we think about health policy and the investments that we need to make? And I think the short answer from both of you is yes, and yes, that we do need to learn from this. Obviously, here at CEDA, we'll do everything we can to actually continue those conversations and promote that direction, because that's what we absolutely need to do. And we're in the midst of this now. We've come a long way, if I can paraphrase Raina's comments, and now's not the time to lose sight of what's possible and the benefits that we can build on the back of the response that we've had to date. Thank you both for your comments and insights, and Christi also for your setting the scene at the beginning of our conversation. There are dozens of questions that are still in the pigeonhole box. I apologise to the audience. You can understand that wrangling those questions and trying to get the conversation working the best possible way when there's just so much interest and appetite is a challenging one. We'll see if we can perhaps get some answers to some of those questions for you and make sure that they go out to the audience as well. But please let me thank our speakers again for contributing your valuable time and insights. You can tell by the interest that it's a really important topic and one that is so critical to both our economic and social future, and your insights are really a valuable contribution to those conversations. In a really terrible plug of self-promotion here, if you are interested in the rapid antigen testing, I did a podcast with the managing director and founder of Illum, which is a company here in Australia that actually produces those tests. And it's about 30 minutes where he explains everything you need to know about the tests and the role that they can play in helping us manage the COVID epidemic from here on in. Thank you again for your time and engagement and being interested in CEDA's events. You have, of course, the opportunity as the audience to give us some feedback on your experience and how you've enjoyed it or otherwise. Please feel free to give your feedback on how well I've managed the Q&A or not. You can do that through the Pigeonhole app. As always, we've got some other tremendous events coming up. jump onto the website ceda.com.au, where you'll find all the information about what we've got in the pipeline of our events in the next weeks and months. The one I will just sort of flag is that we do have Julia Gillard coming to talk again, wearing her Beyond Blue hat. Always a really popular and interesting conversation with the former Prime Minister. With that, I think that's all I have to do other than to close out by thanking Christi and GSK for their sponsorship for what will be a series of conversations. And obviously we've got a little bit to run yet. So please continue to engage with us and we'll do what we can to inform the conversation and the debate. Thank you and good afternoon.